Overkill.
We get too warm.
We're recording.
Yeah,
Great.
we are now on the record.
Now recording.
Oh, okay.
We need to keep this normal because it's supposed to be cold. Building. I know we're waiting for just one more person, so we're just waiting on anything. Great. All right, well, let's get started. Kia Koto, welcome to the Bioethics Centre seminar for this week. It's a real pleasure to introduce our speaker for today, Dana Howard. Dana's been visiting us here in the Bioethics Centre for the past couple of months. But when she's not visiting us in New Zealand, Dana's assistant professor in the Division of Bioethics at Ohio State University, and also a member of the philosophy department and the Centre for Ethics and Human Values at OSU. We've really enjoyed having you in the centre, Dana. It's been really fun, and thank you so much for joining us for the seminar today. So I'll turn it over to you. Oh, perhaps just before I do that, actually just a few, we'll have time for questions at the end, and we've got some people joining us on Zoom. So we'll have an opportunity for everyone to ask questions, and I'll make sure we open it up to our Zoom participants as well, but also our Zoom participants can put questions into the chat as well, that we can read out. Thank you.
Thank you so much. And thanks everyone. It's been a joy to be here, and I'm here for another month. So I take coffee like meetings, and I would love to just hang out and talk shop. So this paper the project is on the value of non-domination in supported decision-making for research participation. And the talk grows out of a collaborative project that I'm working on with Alison McCarthy, who's an assistant professor at the Center for Biomedical Ethics and Society of Vanderbilt. And we've been developing an account of non-domination in clinical decision-making settings. And one of the things that we've been thinking about is whether some of this could apply to the research participation setting. So that's sort of where this project is going. And so, the main question that we're thinking about is, how do we engage in research that is inclusive, is non-paternalistic, but also it guards against abuse of people with intellectual and developmental disabilities. And it's a really, it's a hard needle to thread, right? And so one of the things that we've been thinking about is this political concept of non-domination a useful concept to think about what the principles and norms should be to guide our policymaking when it comes to supported decision-making and sort of thinking about informed consent and participation in research. All right, so there's, one way you can think about 3 stages of research ethics, at least in the US context. And I'll say that this is all growing out of the US context, but I would love to hear from you about, parallels or contrasts between New Zealand. And I'll get to that a little bit at the end, but I think there's interesting differences between the US and the New Zealand context. So there's 3 stages of research ethics in the US. There was this stage of extraction, then there's this sort of stage of robust protections. And then there was this sort of movement towards inclusion, this idea that protection itself was not enough to cover all of the ethical issues that come when it comes to responsible research, sometimes including grassroots groups like ACT UP, thinking about therapeutic orphans like pregnant participants, sometimes actually excluding whole groups from research participation or prioritizing certain research questions over others, makes it so that certain important scientific questions will get answered for particular participants. And so there has been this sort of, I think, move to think about inclusion as well as protection as an important component of responsible conduct of research. And so I'm going to start a little bit with extraction and sort of talk about non-domination and how it's useful in like the history of research ethics in the US, and then move into protection and inclusion. All right, so extraction. So, for most of the early 20th century and the mid 20th century, there was this idea that research was a sort of utilitarian enterprise. We benefit society and we burden a vulnerable few. Louis Lasagna, who was a large figure in research, a researcher and figure in thinking about developing the research enterprise in the United States, said in clinical investigation, as in other societal activities, the good of the individual and the good of society are often not identical and sometimes mutually exclusive. I believe it's inevitable that we will continue to benefit on some occasion from the contributions, sometimes involuntary, of the few. And it should be noted that often the few were people with intellectual and developmental disabilities. So when we're thinking about engaging in creating policies that are respectful, we also have to grapple with the exploitative past, right? And so I'm going to talk about the Willowbrook case in a second, because I think that thinking about non-domination is really useful in that case. But it should be noted that, like, in the United States, by 1972, more than 90% of all investigational drugs were first tested on US prisoners. And if you look at who made up the population, 40% of the inmates at the time were likely to have intellectual or developmental disabilities. And in general, not only in incarcerated like prison settings, but also institutional settings of other sorts, this population served as a convenient sample. They were easily monitored. And they were also sort of removed from society. So there was a lot of reasons for, or not reasons, but a lot of like excuses or uses to make use of these populations that were incarcerated and institutionalized. And one of the sort of most infamous cases is the Willowbrook hepatitis experiment trial. And, just sort of to cover the general gist of what happened, the children of Willowbrook, a state school for children with intellectual disabilities, were injected with or fed a hepatitis virus in order to track its progression, amongst other sorts of research projects. There was at the time a long wait list to have your child admitted to Willowbrook. Dr. Krugman, who was the PI of the study, offered several parents the ability to jump the line and have their children put in newer, cleaner research wards with more staff if they joined the experiments. So there's been a lot of questions about whether or not the parents were really providing proper consent to participate in this research, what they knew. But one thing that I think is really interesting, and sort of to motivate this idea that domination is a useful way of thinking about what was going on, is one of the really good features of the Willowbrook experiments is that there's this ongoing back and forth in medical publications where Krugman and colleagues defend their work against critics. So there was this like public discussion about why they did it, why they think it's justified. And I think it's actually really informative and telling to see what their justifications and rationale for it were. So Krugman, in a series of sort of responses to critics, defends the study in a number of ways. He says, the children were under no additional risk, given the inevitability that all would contract the disease, given the conditions of Willowbrook. He said, by purposeful injection, the children would contract the disease in a mild form under controlled conditions and receive good care and be monitored. He appealed to previous successes in immunization research that he had already had. And he also appealed to the fact that the parents had given consent to their children's participation, right? And so one of the things sort of, and this was not only Krugman and colleagues, this was other colleagues that were independent of the project also defended Krugman along these lines. They said, how much better to have a patient with hepatitis accidentally or deliberately acquired under the guidance of Krugman than under the care of a zealot, right? So I think one of the things to sort of articulate is exploitation was the outcome of the Willowbrook trial, but I think domination was an underlying structural condition that made the outcome possible. And what do I mean by domination? So there are three features about the Willowbrook hepatitis experiment, but I think in general, when it comes to institutionalization and a lot of sort of vulnerability that people have that lead to domination. So first, the parents' choices were constrained. So they were trying to decide whether to admit their children in a situation where they didn't necessarily have that many options. Second, neglect and care in the sort of healthcare setting led to shifts in thinking about the risk-benefit assessment from the researcher's perspective. So the fact that the Willowbrook in general had hepatitis that was prevalent made it so that the children wouldn't be experiencing any elevated risks by participating. And this is, I think, really relevant. The researchers enjoyed unchecked power over these children and their parents to impose their own conception of risk and research benefit. So, I mean, in some ways, I think that this third feature is really the most important component when it comes to the concern of domination. And it's also the most pervasive component. It didn't only happen in Willowbrook, it happened throughout the 60s before there was really independent oversight of research and like a more sort of regulatory structure in the United States. Basically, researchers used their own judgment about risk-benefit analysis, what was appropriate, what wasn't, and they had to defend themselves sometimes amongst their peers, but they didn't have any sort of accountability towards the participants in any robust sense. And so one of the things to sort of highlight is that I think that these are sort of classic conditions of domination. And this is Cicero looking very like noble. And one of the things that Cicero articulated is that the most miserable feature of the condition of domination is that even if the master happens not to be oppressive, he can be so should he wish. And so one of the like useful ways of thinking about domination and non-domination is different from like interference or coercion or anything like that. Is domination is about whether or not someone has the power to interfere arbitrarily into someone else's affairs rather than they're actually exercising it. And because domination is about this sort of power relationship rather than what the outcomes are of that power relationship, you can have a lot of well-meaning people trying to exercise their best judgment, and you're still in sort of conditions of domination. And because of that, I think that that's a very useful concept to think about research ethics more broadly, and in particular when it comes to research ethics with participants who have intellectual and developmental disabilities. So there's two features about domination that I think are useful to tease out. The first is whenever domination happens, whenever researchers have the capacity to subject participants to their power, not only when they actually exercise that capacity. So it's this sort of structural feature rather than the actual exercise of it. And also domination happens whenever researchers have the social power to make arbitrary decisions concerning the interests and values of another. And so arbitrary here is like kind of a technical term. We could talk about it in Q&A about what arbitrary means. But basically one way of thinking about arbitrary is unaccountable, right? So it's like they get to be the arbiters of the decision-making without having to account by anyone else. Yeah, I think that that's all I want to say about, oh, the one final thing that I'll say about domination that is not on the slide which is why I found domination to be a useful concept for thinking about this, is one thing you'll notice about the wrong of domination, and this is different again from like coercion or interference, is that the wrong of domination doesn't require that the person that is being dominated has the capacity to make autonomous decisions, right? It's not that you could be dominated without having full agential capacity. What you are dominated if someone else has the capacity to subject you to their power arbitrarily, right? And so I think this is really useful when it comes to thinking about the wrongs that often happen with people with intellectual and developmental disabilities, because they may not have capacity to provide informed consent. So the anecdote to domination isn't just let them make their own decisions, because that's not necessarily appropriate either, right? Okay. All right, so while the Willowbrook experiment is a particularly egregious case study of the ways in which conditions of domination were present in research practices during most of the 20th century, it's representative of the way in which researchers wielded this unchecked power to impose risks and burdens of research participants. And this is sort of, I think, encapsulates like the way in which they sort of had this arbitrary power. So this is I forget, McDermott. He was a big proponent of like sort of really modernizing the FDA and sort of regulatory oversight. So this is what he said about sort of the power of researchers. So he said, there's no escape from the fact that if the future good of society is to be served, there will be times when clinical investigator must make an arbitrary judgment with respect to the individual. Society may not have given us a dear blueprint for clinical investigations, but has long given us immense trusts to handle moral dilemmas of other sorts, including many in which, in effect, we have to play God, right? So it's like, it is this immense power that was already recognized at the time. And that was a problem, right? So, there were these horrors of Tuskegee, Willowbrook, and other sort of infamous cases really led to regulatory reform and oversight in the United States that mostly focused on protection, right? And that did a lot to curb the arbitrary power of researchers. So I'm not saying that but so it got at domination a little bit, but not fully. And so I'll explain how the protections helped and what gaps are still present in the protective sort of ethos of the regulatory structure of the United States. So basically, protection of human subjects is equated to voluntariness for those who can consent and protection from undue risk for everybody, and for those who cannot consent, mostly thinking about protection from undue risks. So, in the Belmont report, respect for persons is cashed out as the idea that individuals should be treated as autonomous agents. And second, that persons with diminished autonomy are entitled to protection. I worked a lot on really thinking about how to respect persons with diminished autonomy. And one of the things that I've thought about is just because someone doesn't lack or doesn't have full autonomy, that doesn't mean that they don't have other kinds of agential powers that can't be insulted. And so there is, I think, real room for fleshing out what respect for persons means for people with diminished autonomy beyond just protecting them from undue risk. And then further in the Belmont report, where they cash out what it means to respect people who have determined to lack capacity, I mean, I think actually usefully, it's a little bit vague. So what they say is some persons are in need of extensive protection, even to the point of excluding them from activities which may harm them. Other persons require little protection beyond making sure they undertake activities freely and with awareness of possible adverse consequences. The extent of protection afforded should depend upon the risk of harm and the likelihood of benefit. So this is really not giving a very definitive rule about what should be done, but it is giving some guidelines about in practice how respect for persons should be implemented. And in the United States, there's been sort of, though it's not part of the common rule, there's been some sort of consensus about regulations and how we should include people with intellectual disabilities in research. So the first sort of way in these protections are cashed out is the necessity requirement. So people determined to lack capacity can be included only when the study cannot be successfully conducted without their enrollment. Second, there's the benefit requirement. This is going to look very similar to research involving children. So people determined to lack capacity can be included only when study participation offers them, particularly as individuals, some prospective benefit. Third, there's the minimal risk requirement. If research participant offers no prospective direct benefit, people determined to lack capacity may still be included in the research, but only when study participation is not more risky than they would typically encounter in their daily life. So it's no more than minimal risk research. And then finally, sorry that you can't see this, but surrogate authorization. So people determined to lack capacity basically is operationalized in the United States with there has to be a legally authorized representative to authorize participation plus assent from the individual participating, right? And so that's sort of how respect for persons and protections are operationalized. I don't know why it's not.
Oh, sorry.
Yeah, okay. So I think that this is a very protectionist regime. I think it's very similar to New Zealand, but I would love to hear if there are differences between the US and New Zealand. And there's been sort of three problems with this kind of regime. So the first two, exclusion and paternalism, I'll go through pretty quickly because they're not my arguments, they're arguments that other people have made. And then third is it still leaves room for domination. Okay, so the first is exclusion, the second is paternalism, and the third is domination. All right, exclusion. So one worry is people with intellectual and developmental disabilities may become therapeutic orphans, right? So the overprotective research programs have cut them out of gaining from socially valuable research. Now you might say, well, how is that really, how are they losing out of socially valuable research? Well, I mean, I think about, you might think about the intersection of different kinds of conditions. So like people with Down syndrome have a higher propensity of having certain other comorbidities, including Alzheimer's, right? And so if you have an Alzheimer's study that requires people to have capacity to agree to participate in the study, at least at the beginning of the study, right? Maybe they lose capacity throughout the study, then you might actually not allow for certain people with certain specific types of intellectual disabilities, and they might actually lose out given their medical conditions and comorbidities. Anyway, so that's sort of one idea of how people can potentially be excluded. Another idea is just is paternalistic. So it's like even if they're not excluded, it's like it's excluded. I mean, the exclusion for the individual participants is like telling them what to do in a way that they actually have capacity to make their own decisions about. So basically, participants with intellectual and developmental disabilities could be excluded from research that aligns with their values and expressions of their agential capacities. And Daniel Mintz and David Wasserman, Kevin Mintz and David Wasserman have this really nice paper, Research Ethics and Intellectual Disability, where they try and develop this point. But one of the things that they highlight is there's a lot of empirical research that attests to people with intellectual disabilities wanting to participate in more research and valuing research participation in its own right. And their interest in participating in research is higher than what members of IRBs predict that it would be, right? So there's a sort of mismatch between willingness and interest to participate in research and the way in which certain people are excused in exclusion, if that makes sense. So Kevin and David argue to presumptively exclude people with intellectual disabilities from participating in general health research, or to include them only as a last resort, assumes that they're all incapable of knowingly taking on a certain level of risk for the sake of others. This assumption from our perspective is unwarranted and demeaning. So, I mean, I think that we should be cautious about thinking about the kinds of risks and the complicated nature of different research projects, but there are going to be some more than minimally risky research that people may be able to agree to, even if it's not a benefit to them and it aligns with their values. That's basically the idea. All right, and then so those are some two ideas that have come up related to the sort of protections. But one of the ideas that Ali and I have been thinking about is maybe it's also keeping domination at play, right? So one of the concerns that we have is regulations don't guard against all forms of domination in research. And then also, and it's related, not all dominating research is actually going to be risky. So there's going to be some research focusing on health conditions that are correlated with intellectual and developmental disabilities that may have higher risks, but align better with the values and research priorities of members of the intellectual and developmental disability community. So I'm going to go through both of these problems more specifically. So here's the first problem is not all domination is covered. Sometimes I think minimally risky research may itself be dominating, right? And so we could see this when it comes to some forms of genetic research with like autism. So here's an example that came out in 2014. There was this MSSNG study that was sponsored by Autism Speaks. It's a nonprofit organization in collaboration with Google, Sick Children's Hospital in Toronto, and DNA Stack. And the project aims to sequence 10,000 biosamples from people related to autism. So I think it was family members of people with autism or autistic people themselves. The project changed its name to MSSNG as the planners believed that the two omitted I's represent the missing information about autism of ASD. And then the idea was the MSSNG data are going to be made available to approved researchers. So on the day that it was announced, the same day the hashtag not MSSNG emerged on Twitter amongst a backlash related to this. So what did people say? I am autistic and I'm not missing. I am right here and I can speak for myself. Autism has no cure because it is hardwired in the brain. If you eradicate autism, you eradicate autistic people. We are here, we are healthy, we are intelligent. I think that's what it says. We are not missing. Please listen to us. For once, autism speaks instead of hurting us, right? And so this is not a representative sample. It's like a sample of activists on a platform, right? But there is a potential mismatch between the people that are making decisions about whether or not to include their children or whether or not to include nonverbal members of their family who don't have decisional capacity and other members of the autism community. So there is a sort of rift that is present. And there is really interesting data that this is also not awesome data because it's like a Facebook, it's not too scientific sample, but it's a large sample and it's a really interesting one, right? Which basically they asked a lot of series of questions about, and they asked it of autistic people and non-autistic people to see what the differences are So one is, if there were a cure for autism, I would take it. So this is autistic people's responses was 52%. And then for non-autistic people, oh, sorry, strongly disagree, it's 52%, right? And then for non-autistic people, it's like sort of everywhere, right? Now, one thing that is really useful about this study, even though it's like, is that they also had self-identified people who are non-verbal or selectively mute, who are often the people who are understood, at least in the research setting, to not have decisional capacity. And they're even more against this sort of idea. So, I mean, it's a very interesting dynamic where there's a lot of issues related to representation, where I think there's just a lot of possibility that there's a misalignment between the values of the researchers and the values of well-meaning family members and maybe the values of the participants. At least there's a possibility, if not, and there's sort of interesting questions. So I think this is sort of a place where it's just a study that is ripe for domination if they agree to participate, right? If there is not this sort of checks and balances, even if everyone is well-meaning, right? And using their own judgment. So the common rule makes risky research out of bounds for vulnerable populations, but as is evidenced with this case, not all problematic research is necessarily risky. And some research, particularly studying intellectual and developmental disabilities, may actually have higher risk, but may align better with the values and research priorities of members of the IDD community. So thinking more about potentially like intervention research related to other kinds of comorbidities. That's still like some prospect of benefit, but like we could think about first in human or something. I'm not actually sure exactly. If anyone has a good case for number 2, that would be great. It's a theoretical possibility. All right. So that's sort of the end of the protectionist section, which is highlighting that the protections do some work at protecting participants with IDD from undue harm, and it does some work in protecting against domination, but it doesn't do all the work of protecting against domination. So how do we engage in research practices that are inclusive and non-paternalistic, but also guard against potential abuses of vulnerable populations, as outlined in the cases that I've discussed? And we're hoping through a non-domination approach. All right, so what does that look like? So we think that supported decision-making is a really useful tool for non-domination. So it's different from the participant-controlled, where the participant has unconditional authority, including the authority to make their own decisions or ask for assistance as they see fit. So we're actually assuming that supported decision-making allows for collaboration between the potential participant and the trustee, what we were talking about, but the supporter. And it's different from substituted judgment, which is currently the way in which the United States regulations basically allow for it. So substituted judgment is just the legally authorized representative. So what do we mean by supported decision-making? So this is, the American Bar Association has talked about supported decision-making as an alternative to guardianship, placing the individual with a disability at the center of the decision-making process, where the individual with support and consultation with friends, family, community organizations, and other resources have the support to weigh the pros and cons of a decision, review potential outcomes, and finally make a choice. And one of the things that the American Bar Association, it takes many forms. In general, supported decision-making is a grand idea, but its implementation is still really up for questioning. And in New Zealand, New Zealand is a signatory of the UN Convention on the Rights of People with a Disability, which the United States is not a signatory of. And so one of the things that is interesting is like the UNCRPD has gone all in on supported decision-making as an alternative to guardianship. And I think I found this like really great, interesting document about like a report about sort of principles for health research with adult participants who are unable to provide consent. And in their discussion of supported decision-making, they say overall, the rights in the code provide for taking a person's wishes into account, whether it be having regard to the person's general views and values or specific and known wishes, or the right to supported decision-making when there's some capacity to consent. So one thing that I love about just sort of that sentence is it articulates all the different ways in which people can have agential powers that do not necessarily amount to full-blown ability to make your own decision autonomously, right? You can express your preferences generally, more specifically. You can have some decision-making powers, but maybe you have memory issues, so you don't actually remember like the choices that you made beforehand. So there's all these different ways in which people can have and express their agential powers that doesn't necessarily amount to full-on informed consent that this report is acknowledging. But the other thing they're acknowledging is, for reasons discussed, the rights can be difficult to put into practice in a meaningful way. And so I'm just going to gesture at some ways in which thinking about non-domination as a value to guide our policymaking might change or sort of be contrasted with the way in which it's normally done, rather than prescribe actually how we implement this, because I think that's really complicated. All right, so supported decision-making really would look different in the following ways from substituted judgment plus assent. So the role of trustee is different. Basically, the trustee in supported decision-making is the trustee has joint authority to approve participation rather than sole authority to approve participation. The role of participant is also different. So they are actively involved in the decision. I think actually this might be a difference in the United States and in New Zealand. While it is ethically recommended that people, like participants, be actively involved, it's not necessarily required for legally authorized representatives to engage. So it's like active involvement could be like a core requirement. With substituted judgment, basically the way in which it's operationalized in the United States is through assent. So whatever the decision the representative makes, then you go to the potential participant, and you ask whether or not they agree to participate or not. So it's after the decision-making process. There's ethical guidance that they should be involved throughout, but it's not a requirement of the law or of the regulations. Achieving an ideal, non-domination is seen as the process rather than, I think often with substituted judgment in general, there's this sort of simulation of like, what would this person want if they had full capacity? And that is just a different sort of ideal than the ideal of both of you together sit down and try and figure this out in a way that doesn't dominate the participant. There's different sorts of internal checks that we talk about in our other paper that I won't get into. And one further thing is you don't have this sort of capacity assessment at the outset of research participation. So in the United States, a lot of times, in order to involve people with intellectual disabilities, you have to have a capacity assessment to see if they have informed consent capacity. You could just sort of do away with that evaluation and have the supported decision-making process available for everyone. And one of the things, talking to a lot of researchers that work in this space, they really find the capacity assessments to be like problematic and not something that they feel comfortable with and frustrated about, and sort of why is it that we have to do it for this population, not for everybody else? We have all this research that nobody understands what they're signing up for. Why are these people singled out? So it's like, in some ways, at least for some we could think about minimally risky research. We just do away with the capacity assessment and include the supports and see if that actually supports people's decision making more effectively. All right, so I think that is all that I'm going to say for now. But I would love to hear your thoughts and questions.
Right. Thanks, Simon. Okay, we have plenty of time for some questions, so open it up. Mike, do you want to kick us off? And people on Zoom can also put their hand, use their raise hand function on Zoom to signal if they have a question, as well as unmuting. Thanks, Mike.
Thanks very much, Dana. So the example that you used, the Willowbrook one, and I think the one that gets people feeling kind of favorably disposed towards the non-domination stuff, is always things that involve some harm, some sort of wrongful, arbitrary intervention of some other person. And I'm just thinking, the account that you give of non-domination doesn't require that at all. So you can, like the classic Republican freedom cases, that is the slave, with the benign master, obviously that's a bad thing. And, Hobbes's account of freedom, that person's free as long as the master isn't intervening and everything. But obviously slaves aren't free. Right. So republicanism does a good job of sort of accounting for our intuition about freedom. But I think in your case, the tricky thing is trying to make plausible that domination's always wrong. And where it does seem most plausible is when people are made worse off, and Willowbrook may or may not be like that, sort of setting aside the back with Brigham and so on. But those examples seem like good ground for you. I was thinking of the things you were saying and how they would apply to pediatrics. So I think for the disability community, you get much more, well, and maybe this is the case for, for kids as well. They're going to vary in their agency and all of that. But for people in the disability community, you're going to get all sorts of people who are able to speak for themselves. There's some pediatric research where no one can speak for themselves. Yeah. And it just seems to me that domination here, if it looks like it's present on your account, but it also seems to me not wrong at all.
Yeah.
And I think that seemed to me like the hard case for your account, if you want it to encompass, as it seems like it should, this other vulnerable group, this sort of the babies.
Yeah, I think that's great. And I mean, so one thing that I will say about I do think that there's an important difference between the pediatric case and the sort of adults with intellectual disabilities case. And with the pediatric case, really, like, guardianship is just appropriate because parents aren't, like, sometimes they're making decisions on behalf of the child, but often they're making decisions for the child as their guardian, and the welfare of the child is sort of like the primary sort of way of thinking about that decision, not like enacting their agency in any sort of way. So it's like it is much more protective, right? So I think paternalism is very appropriate in the like pediatric case, and it's like more problematic in the it could be insulting in the adult case, because it's like, what are we protecting people from? It's like, if they're not ever going to develop these agential capacities, what are we protecting people from? So that's like, so I think paternalism is appropriate. Is domination appropriate in the parenting case? I mean, like, so one thing that is useful about, like, at least the way that Pettit and others have been teasing out what non-domination looks like, is that the checks don't have to come from the people themselves. Accountability can come from third parties, right? And I think that with parenting is a site of domination that I think sometimes is objectionable. I think, especially in the United States, I think parents have a lot of discretionary power to make healthcare decisions for their children in a way that there's no accountability from the outside. And there should be some more. So it's like so maybe thinking about like how arbitrary are parental decision-making powers, and is there some sort of accountability that makes their decision-making powers less arbitrary? And at least in the UK system, parental discretion is really accountable. Like there is these sorts of checks to non-parents, like to the medical team, and to determine whether, and that is not the case in the United States. Sometimes it's the case with like, social services gets involved and stuff like that, but it's usually not because the parents are making like certain medical decisions for their children. So yeah, so that's like a long answer, but like, so I think one thing just to say is like, I would cash out how arbitrary these decisions are in the pediatric setting, and whether or not there are checks. And maybe there should be more checks for like parents in like the research setting about whether or not they should participate. That is similar to the setting the disability case, but I'm not sure. Does that at least respond? Yeah.
Okay, we have John, and then we have a bit of a queue. So go ahead, John.
Thank you. That was super interesting. I mean, I think in general, the idea of looking at research and other issues of bioethics through the lens of power structures and what's dominating is just the sensitive thing we should do. I had a suggestion for something that you might like to dip your toe into while you're here, and also a question. So the suggestion was, what I was thinking about as you were talking was approaches to conducting research with Māori. And there's some really good resources on that. There's one of the very good influential books is by someone called Linda Smith, and she talks about how you would go about conducting research. And one way of looking at this is that it's about power, and it's about the co-design of research. So it just might be, I think that intellectual discipline example is a really good one, but this might be a different one. I suspect that pattern will play out in Canada and other countries with research nations. So if you want any other things to look at, there's a few of us can point towards those. Elizabeth might point you towards the Tierra-Tika principles too, which are different principles. But the question I had was about whether non-domination is like a kind of fourth Belmont principle, or whether it's doing some explanatory work. Because I was thinking about, with the Willowbrook example, and you said this, like the problem looks like it's exploitation. So my question is non-domination the overarching normative principle that's explaining why non-exploitation is important here?
Yeah.
I was also thinking about a number of the examples, and you mentioned that with respect to Willowbrook, but also with the intellectual disability case, some of the problem is epistemic, like it's kind of not getting. So I was also thinking about, does the principle of non-domination say some things about epistemic injustice? So I was interested in the connections between those normative structures and whether the thing sitting behind them is your principle.
Yeah, thank you for all of those suggestions. Definitely follow up about the Maori research principles. So I was thinking maybe the way of thinking about non-domination is a way of freedom. It's a way of respect, like it's a way to cash out the respect for persons, and not its own principle. And maybe exploitation is like actually just like exploitation is just a problem, and it's not in the Belmont Report at all. And it's like definitely much more in Declaration of Helsinki and in SIOMS and more international codes. And maybe the United States should like think about non-exploitation as itself like another pillar of justice or ethics. And yes, so the problem is epistemic. I think that that's right. And I think that actually with intellectual disabilities, it's even like more pronounced. And one of the I mean, in general, it's like you can't do away with discretionary powers in these situations. So it's like there's always going to be some sort of representation going on, some sort of discretionary power, some sort of interpretation going on. Even if you think about like presenting the options in a way that you think are salient to a person, right? Like how you present the options, how you interpret bodily actions. Is that an expression, or is that just a behavior? You know, it's like all of that is just going to be, it's built in. So I'm dubious of solutions that like try and do away with that and try and assume that there's going to be any certain situation. And I'm more interested in sort of relationships of power and like, how do we make this as fair as possible? If that makes sense. Yeah.
Thanks, Dana. I think Simon was next on it.
Yeah, I'll keep this brief good because I think the previous questions have raised this and forgive me if I've missed something. I'm interested in the logic around the non-domination principle. I think I heard you say that just the problem is just having that power. Is that correct?
Mm-hmm.
Yeah. And I think you were just talking about this, but I don't see how we can escape the fact of power. And I don't know if the slave example is really appropriate or apt, because that's that's based on a law that we've made that outlaws a certain kind of power relationship, which we can do, but you can't outlaw other power relations such as parenting or even to be the professional in a situation. I was thinking about when a patient comes to a doctor asking for a prescription of some kind, you would hope the doctor would remain as respectful as possible, and if there's a disagreement, that they'll try to understand and work with the person and explain why what different perspectives and not exercise that power. But at a certain point, they do in the end have to make a judgment based on their responsibilities, which may mean and be experienced by the patient as, well, you've just dominated me.
Right.
But that may, you know, what the professional saying is, I've just done my job. And I mean, it's particularly pertinent for psychiatrists who have to maybe exercise a compulsory treatment order.
Right.
I guess we could debate that. Yeah, I mean, that's maybe I'll just leave it there. I was thinking of the parenting example too.
Yeah.
It's inevitable that I have power over my children. I shouldn't use it, or I should limit how I use it to make them do things, I should say. But I will use it all the time, of course. There's a really excellent article by somebody called Agnieszka Jaworska. I think it's the late night. Do you know that one? Yeah, it just reminded me of
yeah. So I mean, I think I'm agreeing with you on all the things.
Yeah.
So it's like, so it's not doing away with the powers. It's trying to do away with the arbitrariness, or at least like,
So
well, we need to like that, the arbitrariness of the way in which the power is enacted. That's sort of the angle of intervention.
does that mean that it needs to be a justification for the power?
Yeah, so it's like justification for either the power or justification for the decision. There's some role for contestation.
Yeah.
Even if the child doesn't understand, you know, like that sort of stuff. So you don't get rid of the power, but you sort of constrain the arbitrary uses of it.
It sounds right. Thank you.
Thanks, Dana. Taryn, did you want to go ahead and ask your question? Are you there, Taryn?
Yeah, sorry, it's just making a cup of tea, so I'll move away from the kettle. Yeah, so I was interested in the difference between paternalism and domination, and I think you've kind of answered that with response to Mike's question. The other thing that I was thinking about, because I've worked in with people with intellectual disabilities, like as a support worker in my 20s, and I think this is a really unfair criticism, so let me just put that up front, because I think what you're doing is super important, but there's just not the funding to to implement it in any way. So we would used to have these these meetings where we'd have lifestyle plans and we'd try and get people to make their own decisions and stuff. And it was just a joke, really, because there's not that these people that are doing this don't have the training for it. So that's my my unfair comment is, well, how is this going to is it going to be put into practice? And then my next comment was something like, you said it towards the end, I think this could be applicable to all people. And I really think there's something in that. The older I get, the more I realize I sort of have this humility about even what I know about myself and about how the perspectives of others can feed into that. So I was wondering what you thought about having this sort of non-domination approach for everybody, not just people who have intellectual disabilities. And that might be a way of, a sort of practical way of getting it more accepted into society. So
I think that's, yeah, great. So no funding to implement. Yeah, I'm an ideal philosopher. I think
yeah.
one thing to articulate is like, well, maybe not in general. In like, it is interesting how supported decision making has manifested itself in like life planning and like financial planning in this like very robust way. And that's hard. And maybe like it actually works better in the research setting because it's a very limited decision about a very specific choice of like, are you going to participate in this research protocol or not? The thing about everybody, yes. So, I mean, I do think that one thing that is a nice feature of, at least with like non-domination and like in the medical setting, is that you end up not having two different ethical sort of norms, one for people who have decisional capacity and one for not. It's just non-domination throughout. And then it may actually manifest itself differently depending on the different needs and supports that people have. But one of the things that Ali and I say in the other paper is like, lots of people don't want, if they're actually enlisting a friend or a trusted loved one into their medical decision-making, they don't want someone that is just going to sit back and just present the options as neutrally as possible. They like actually want an interlocutor. And it's like, not everybody, but some people do. And so let's make sure that that is not dominating. And then let's make sure that it's not dominating in the like case where someone has been found to lack decisional capacity. So that's sort of the way in which we sort of motivated the other paper, at least.
Yeah, really interesting. Thank you.
Yeah.
Thanks, Taryn. Thanks, Dana. I think we have time for one last question. So
Thank you. Really enjoyed your presentation and moving particularly from paternalism to protection and to inclusion. And so just very briefly, this is very timely, your work for New Zealand in terms of the whole issue about how we establish a legal framework to allow people with diminished capacity. And you pointed out the Health and Disability Commission work, and there's also the Law Commission here in New Zealand, and I'll put you in touch with them. But I really want to just drill down briefly as to, so how do you, it follows on in a way from Taryn's sort of comments, how do you kind of operationalize the term which you referred to as a trustee, and that's a new kind of term for us, and I quite like that. In terms of, and also, you know, your work in that space, because how you actually implement supported decision making. Have you got any sort of brief comments around that?
So one of the ways we've operationalized it in the medical like decision making setting is, so there's I mean, there's going to be room for like contestation for the person that is, so the person who is the decider, they get to choose who their supporter is, right? Who their trustee is. And then they also have, there's part of the deliberation is like moments of questioning whether or not they agree with how things are going. And they can refuse or change course without any sort of justification, right? So like thinking about how to provide avenues of contestation for the participant.
So what do you mean by contestation?
Oh, just like, do you agree to this? Do you want to continue with this person? Do you trust, do you feel like you have all the information? Those sorts of questions. So like guiding questions.
Right.
So that's one thing. And then the other thing that we were thinking about, but I would love, I mean, this is like, you know, the other thing that we were thinking about is justification. So how does, so let's say the trustee, the person that is the supporter is, and we call them a trustee because in some ways, the way we've been thinking about it is there's a more active role for the supporter than sometimes people
But
think
it
about
implies
with
duties,
supported.
doesn't it?
What?
It implies duties.
Exactly.
Yeah.
Yeah. And so so that's why we use the language of trustee, because they're entrusted to make this sort of decision and they have these sort of fiduciary responsibilities. And so we were thinking that they have to justify the decision if in terms of the stated values, if there are any, of the participant, right? So, and that doesn't necessarily need to be unjustified only to the participant. That's to everybody, and the participant may not even understand the like alignment, but there has to be sort of a direct justification for the decision that comes from if there are explicit or stated values from the participant themselves. So that's like another thing. So, and this is going back to this sort of arbitrariness. So sometimes it's not going to be the participant themselves that may want to contest the decision because they don't see how the choice really aligns with the values. But there has to be this justification that is only the responsibility of the trustee. It's not necessarily the responsibility of the participant themselves. So the participant doesn't need to justify their choices. Their choices have authority regardless, but the trustee basically gets this continued power through good faith justification, if that makes sense. That's how we thought about in the medical case. I don't know how it would translate in the research setting.
Yeah, that's right. It goes right across the board.
Yeah.
Thank you so much. We're at time for the session, for the formal part of the session, but maybe there's a little bit of time for some informal questions. But thank you so much, Dana.
Thank you.
Coming from John. Yep, so that's great. So I'd echo that sentiment. Absolutely. Thanks very much for a fantastic seminar. Thanks everyone for joining us. And yep. Thanks everyone who joined us.
Who's the top cost?
Oh, that was just from Taran saying, don't worry about my question.
Oh, I see.
You've run out of time.
That was a good question.
Yeah. Okay.
Yeah. Thanks. Yeah, no, so I'm Alison's. I'll give you my card if you like.
Yes, that would be
because
great.
so there